Today, I'm going to talk about new treatments for people with rheumatoid arthritis. So if you have rheumatoid arthritis or if you know someone who has rheumatoid arthritis, this might be very valuable to you. I wanted to talk about exciting things that are happening in the world of rheumatology for my patients. And I know that a lot of you will ask themselves, what is out there? What is coming? What is exciting? So if you have questions along the way, I will welcome you to leave your questions and I will answer them in the end. But I wanted to start with something to tell you about rheumatoid arthritis, because this is probably the most common autoimmune disease that we see in rheumatology. It's actually the bread and butter of my practice. I see a lot of patients with rheumatoid arthritis, and along the years, I have learned so much, not only from books, but also from my patients. And I can tell you that every single patient is different. Not a single patient will present the same. There are some features of rheumatoid arthritis, of course, like the joint pain, especially affecting the small joints, especially in the hands, the wrist, but it could also affect the small joints from the feet. But there are patients that will present with pain in their shoulders and not necessarily the small hands, the small joints in the hands. So because of that, I wanted to let you know that, the fact that you have certain symptoms that don't match the book doesn't mean that you cannot have rheumatoid arthritis or you don't have rheumatoid arthritis. So every patient, being unique, needs to be addressed differently. Because rheumatoid arthritis is one of our diseases, I want to tell you a little bit about how we diagnose the disease first, and then we'll talk about treatments. Rheumatoid arthritis is diagnosed based on your clinical signs, clinical presentation. And it's very important how you collect and how you present those signs or symptoms to your doctor, because in this way they will understand how this disease came and how this disease progressed. Many patients that come to my practice, rheumatologist on call, they will tell me about starting to feel very fatigued. So that's another sign of rheumatoid arthritis. Or having symptoms such as dry eyes or dry mouth or being short of breath. This could also be part of rheumatoid arthritis, not necessarily to have only joint pain. But many patients do not know that those are symptoms that could also be related to rheumatoid arthritis, and they don't think about telling their doctors about these signs or symptoms. The other thing is, it's important to know that we do have blood tests to diagnose rheumatoid arthritis. One of them is called rheumatoid factor. The other one is called anti-CCP antibodies, which is very sensitive for patients with rheumatoid arthritis. But there are also newer types of antibodies, like vimentin antibodies, that are now used in clinical practice to diagnose patients with rheumatoid arthritis. The other thing that is important to know is that about 30 to 40% of patients with rheumatoid arthritis, they might have negative rheumatoid factor and negative anti-CCP antibodies. And we call those patients seronegative rheumatoid arthritis. And now let's go down to treatment. You probably heard about the methotrexate, you heard about biologics, you heard about JAK inhibitors, but we have to learn what is coming new in rheumatoid arthritis treatment. And I wanted to tell you that in 2025, the EULAR, which is the sister of American Congress of Rheumatology, they also released the new guidelines for rheumatoid arthritis. And what they talk about is something important, something that I explain to my patients every single day in my practice. I tell them about the first step in treating rheumatoid arthritis is choosing a drug called methotrexate. And probably those of you that were diagnosed, you heard about methotrexate. And if you go online and you Google it, you're going to find out that methotrexate is a chemo drug or a drug that is used for patients with cancer. But in rheumatology, we use it for many, many years. I think about 40, 50 years of use, and we use a fraction of the dose that is used for patients with cancer. And there are many discussions that we can have about methotrexate, but what I wanted to say is that still in 2026, the EULAR or the organizations that is writing the guidelines for patients with rheumatoid arthritis, they still recommend methotrexate as the first initial step. For some patients it's good, for some patients it's not. So in those patients that it's not effective, or for those patients where the methotrexate is not tolerated well, then we have the next step, which in their recommendations and even in my practice are the biologics. And there are multiple classes of biologics that you can choose, from TNF alpha inhibitors to IL-6 inhibitors to other classes of biologics, but biologics are the next step. And after that, you can choose JAK inhibitors, which are the pills. You know, a lot of the biologics are injectable medication, and they come either as a pen or they can come as an infusion. And then we have the pills, which we call JAK inhibitors. That's the name of the class, but there are many types of JAK inhibitors that we can use, from Xeljanz to Olumiant to Rinvoq. We can use multiple classes of JAK inhibitors. But what is interesting, and I want to draw the attention here, is that for the very first time, these guidelines, they address the patients that are in remission. So what is remission? Remission means that after you have been diagnosed with rheumatoid arthritis and you have been on treatment for a while, or, you know, in some cases of mild rheumatoid arthritis, just by adjusting lifestyle, you can get into remission, meaning that you have absolutely no symptoms. And on top of that, your markers of inflammation can be normal, but you function normally. You function like you don't have this disease. So that's what remission is called. So these guidelines were talking about remission, and they were saying that for those patients that got into remission, so again, no symptoms, they feel fine, we can start tapering down on the medication. And this is something that I have done for many, many, many years. I don't keep patients forever on the same medication to the same dose. If I see that the patient gets into remission, there is an opportunity for me to start tapering down the doses of medication. And I think it's important for all of us to learn from that, because that will allow the patient to get the minimum amount of drug that will control the disease, but will also minimize the risk of suppressing your immune system to cause an infection or to cause cancer. And I think that's very important for a lot of rheumatologists to learn and to apply in their practices, to start tapering down the doses of medication. Just don't refill the medication forever. Once the patient is in remission, and if you're a patient that you are in remission, you should have that kind of discussion with your rheumatologist. That's what I do in my practice. That's what my partners are doing in my practice. Because once again, it's important to protect the health of the patient. It's important to expose your body and your immune system to the least amount of drug for the least amount of time, and to minimize the risk for side effects. Now, you are probably curious to find out if there are new drugs coming, and there are. There are new drugs coming in the market. There is a type of drug that is very similar to TNF alpha inhibitors. It's called a nanobody, meaning that that molecule of that medication is very, very small. And why is this important? Because based on the studies that were done in Japan, this drug is called ozoralizumab. So once again, ozoralizumab. And in 2025, there were phase 3 trials published about these drugs, once again in Japan. This is not available in the United States at this point, but they have seen with this nanoparticles of medication, the effect of the drug was visible in a few days, not in a few months, like we see for TNF alpha inhibitors. It is given just once a month, not every week or every 2 weeks, like many TNF alpha inhibitors are given. And they have noticed that the site reaction problems or injection site reactions were much, much smaller. And it was even given in those patients that in the past, they failed a TNF alpha inhibitor drug, something like Humira or etanercept. Now, newer drugs, and this is very exciting for me because I was looking a lot about the use of immunotherapy. What is immunotherapy? You're going to ask me what's immunotherapy and how is it different from the drugs that we use today? So most of the drugs that we use today, they suppress your immune system, meaning that they will tell your immune system to quiet down. Like they're gonna reduce the function of our immune system, which is activated and starts attacking your body. So immunotherapy is gonna tell your immune system there is no need to react, but it doesn't suppress the function of the immune system, which is much, much different. And immunosuppressive drugs, they started to be used in patients with cancer. You probably heard about immunosuppression used for patients with lung cancer, for example. Those drugs, they are called PD-1 or PD-1 ligand. They are new for cancer patients, but they are also new for rheumatoid arthritis patients. And a few years ago, there was a study published with one of the drugs from immunotherapy drugs. The drug was called peresolimab. So once again, this is a new drug for me as well, so it's hard for me to pronounce the name. But this drug actually, it was used for patients with rheumatoid arthritis in phase 2 trials, and it showed a very impressive safety profile. But the reality is that with all these drugs, all these immunosuppressive drugs, they can also cause autoimmunity. We know from patients with cancer that in some patients, they can increase the autoimmune arm. So we still don't know for sure, but it was used with success in patients with rheumatoid arthritis. We just need new data. There are new JAK inhibitors that will come. We have 3 already on the market approved for rheumatoid arthritis, as I was telling to you, Xeljanz, and then we have Olumiant or baricitinib, and then we have Rinvoq or upadacitinib. But all these drugs, they act on a different pathway. As I said, they are pills, not injectables. And now we have at least 2 other JAK inhibitors that will be approved very soon. And what excites me even more is precision medicine. What precision medicine means, at this point in time, we choose a medication based on our level of comfort. When I say we, I refer to physicians. If we use a drug that we know that it was working, and I'm going to give you an example. For example, Humira or adalimumab was used for many, many years in our practices with great success. And we know that for the majority of patients, Humira works, or etanercept, that works as well. So because we use that drug for a long period of time, we are comfortable with the drug and we're going to recommend to our patients. But in some patients, that drug does not work the way that we expect. So we are going to drop that drug and we're going to try another one. So it's unfortunately, for the patient who has to suffer through this process, it's a trial and error situation. So what excites me about precision medicine is choosing a drug that we know has the best chances to work in a patient. And that is important because the more we understand that there are different types of disease, I would say, variants, because not all the patients with rheumatoid arthritis, as I said, are the same. As we discover more, that there are different profiles, I would call profiles, for rheumatoid arthritis. That means that we can choose a drug that will be better for that profile of the patient. Now, the researchers a few years back, they started to collect synovial biopsies. So what they did, they took a small piece from the lining of your cartilage in the joint, and they look at that piece and they try to identify what kind of features that piece will have. And because of that, they learned that there are, at least right now, there are 3 types of synovial biopsies profiles. One where there are a lot of lymphocytes. So a lot of lymphocytes that will produce probably antibodies. And they have seen that in that particular type of patients, rituximab or IL-6 was beneficial. And then they identify another type of synovial biopsy, one where macrophages are other types of immune system cells. They were more active there, or they were more expressed there. So with that, they saw that certain drugs like IL-6 inhibitors, for example, tocilizumab, they work better for that category of patients. And then the last variant that they identify, they call that posi-immune, meaning that there were not many immune system cells, but there were a lot of fibrosis happening in those tissues, or this synovial biopsy. And in that category, they figure out that that category of patients is the patients, or are the patients that are responding the least to the biologic medication. So now they are looking into new pathway to address, or addressing new pathways that could help those patients where they don't have too many immune system cells, they have more fibrosis. And that's why probably the treatments that we were giving to these patients were not working. So again, I think that kind of precision medicine is coming. It's closer to us, and we as physicians, we should open our ears and start thinking, how can we address that kind of need for our patients. The other thing that I want you to understand is about my practice and about the treatment of rheumatoid arthritis is that it needs to be individualized to the patient. It needs to be personalized to the patient, because as I said, there are not two patients the same. And if you are in contact with the patient and you understand the type of the disease that they have, you will be there able to address the needs of the patient. The other thing that I am a huge fan, and not only fan, but I promote it to my patients in my practice, is the need to incorporate a certain type of lifestyle. And when I take this lifestyle word and I break it down for my patients, and I break it down here in my channel, Rheumatologist on Call, I tell patients that it's important, or this disease should be the bell to draw your attention towards what you need to do that will improve the way that you feel with rheumatoid arthritis. And that is your nutrition, addressing the way that you eat, what you eat, and then your exercise, and then how you manage your stress and how you manage your sleep. All these 3 or 4 pillars are very important. So once again, nutrition, exercise, your mindfulness, and your sleep. All these 4 pillars in your life are very important. If you watch my channel for a long time, or you're new to my channel, you know that I have written a book. I wrote a book about rheumatoid arthritis. It's called Thriving with Rheumatoid Arthritis. And this is a guide for all the patients in the world that are living day by day with rheumatoid arthritis. And they will learn a scientific way of managing their lifestyle, from what are the foods that they need to eat, what are the types of exercises that are good for them, and how to manage the stress better. And because we are mentioning about the stress, I want to let you know about also something that is coming in reality. You probably heard about vagus nerve stimulation. There are many devices out there. And for patients with rheumatoid arthritis, why is it important to stimulate the vagus nerve? This parasympathetic nervous system that we have, its role is to calm down our nervous system, but that is also connected with your immune system because the vagus nerve starts from your brain and goes down to your gut. And in your gut, you have about 70 to 80% of your immune system. And when your mind is relaxed, that sends down through the vagus nerve a stimuli to your gut to calm down, and the immune system will also calm down, will not be so reactive. So researchers a few years back, they started to publish some very exciting studies about how to modulate the nervous system or the vagus nerve to induce that calm reaction to your immune system. And about a year ago, the FDA actually approved a new device that is an implantable device that will be implanted somewhere here in the neck. And it's called the Set Point. This company, the Set Point company, they published some studies about using that device, implanting that device for patients with rheumatoid arthritis to modulate their parasympathetic nervous system, actually to stimulate the vagus nerve. And what they showed is that in patients with rheumatoid arthritis that they have been on medication, actually adding the vagus nerve stimulation decreased the need for more medication, and they got these patients into remission faster. But as you can imagine, insurance companies are not going to pay for this kind of innovative treatments, or it's going to take a while until they pay. But if you're interested to do something like this, I cannot recommend you a specific product to stimulate the vagus nerve. But even in my book, I put a whole chapter about that, about how important it is to adopt mindfulness, or to do a breathing square exercise, or to do like body screening, body scanning to regulate or to stimulate your vagus nerve. And why do I say that? Because you can use the Audible app, for example. You can start meditating with 5 minutes a day. It doesn't have to be perfect. That's what I tell my patients. My patients have already resources created for them to teach them how to do that. But even starting to meditate 5 minutes a day in the morning and 5 minutes in the evening, it's going to change and it's going to modulate your nervous system to stress less and to give your immune system a break. And you have this chance to get into remission faster. So all those things that I have talked in the book, you're going to find them in my YouTube channel, Rheumatologist on Call. You can watch my videos. You can learn from it. You can share it with other people. So please share my videos with other people, because I feel like education is the key in managing patients with rheumatoid arthritis and many other autoimmune diseases. I'm going to take some questions from here. There is someone that says, I was given methotrexate with prednisone for ankylosing spondylitis. I recall that I was on both for a while. My AS went into remission and I'm healed for 30 years now. Wonderful. Yes, that's true. Ankylosing spondylitis, it's another type of inflammatory arthritis, similar in some ways with rheumatoid arthritis, but also different in other ways than rheumatoid arthritis. And yes, methotrexate can be given with prednisone, and people are helped because of these two medications. If you have any other questions, please don't forget to leave them here in the chat. Many times I take my time and I go through these questions. Maybe I'm not able to go through all your questions, so I would like to thank you very much for watching my channel, for sharing my content, for being part of this community. I strongly, strongly encourage people to become part of this community where we share the real science, where we share the realities. We don't give you just a hype. We don't want to give you the impression that we cure autoimmune diseases. I really appreciate people that invest their time and energy into learning about rheumatoid arthritis and about learning about autoimmune diseases in general, and taking advice from people that they practice medicine. Like me and my partners, I see patients every single day. I diagnose patients with rheumatoid arthritis. I treat patients with rheumatoid arthritis. So I'm not just talking I know about it, but I don't practice every single day. And with that, I would like to thank you very much for joining my live stream, and I will see you soon in another one. Bye-bye.